everyone. Welcome to the Cleft Palate Craniofacial Journal podcast. I'm Pat Chibbaro, your podcast host, and I hope you're all having a great summer. And when I got the email that this paper is almost about to be published, I said I definitely would love to podcast this because I remember when I first started as a nurse practitioner in the late 80s, my surgeon, shout out to Dr. Court Cutting. He was going on missions with Operation Smile, which I didn't even really know anything about it because I was just starting. But then I saw over the years this explosion in mission trips, and it's always been of interest to me. And I've had a lot of questions about it over the years, and I was really glad to see this paper, which everyone, of course, should read. When it does come out, it's almost ready to be published, so be on the lookout for it. The name of the paper is Program Structure and Responsibility in Short-Term Cleft Surgery Programs, the SCALE Framework. And I'm really happy to have the two authors with me today on different sides of the world, David Chong and Janina Kueper, and I'm going to ask them to introduce themselves, and then I'd love to know from them what motivated them to do this work, because it's a lot of work. It's really important work. Really glad to see it. I think it's going to really be helpful for people as they think about becoming involved in these programs. So David, let me have you kick it off.
Thanks, Pat. It's great to be here. I'm David Chong. I'm a plastic surgeon based at Royal Children's Hospital in Melbourne, Australia. And very excited I love being part of ACPA, and so ecstatic that this paper's been accepted and to be part of the family.
Janina, tell us about you, where you are.
All right, happy to introduce myself. My name is Janina Kueper. I'm a rising PGY5 here at the University of Pittsburgh. I'm actually sort of sitting out a little portion of our research day here today, hence the formal wear instead of scrubs. I'm happy to speak a little bit about how this project got started, because it was actually an ACPA conference. So it was the annual meeting.
And I have my 80th anniversary shirt on. I hope others out there have it as well.
Exactly. So this was, I believe, in 2025, was it? I believe in Palm Springs, actually.
Palm Springs.
And David and I ended up having a long conversation about one of the panels that had happened there, where there was a conversation about about global surgical missions and about connecting with local practitioners specifically, because there were some practitioners from Mexico specifically in that room who were reporting on some of their experiences working with the consequences of some of these global surgical missions that come to Mexico that end up this is their language, pitching a tent in front of their hospitals and doing these types of procedures. And we're expressing some alienation with that process of how that was working. Now, obviously, Dr. Chong has extensive experience in the global surgical realm, and we decided that this should really serve as an impetus to write something up and to think about how can we think more critically about the work that is being done and what is an accessible way of bringing that to the people.
It also, as I was looking at it, it seemed to me to be sort of a guideline for anyone who was interested in becoming part of one of the programs, because I think one of the things that that you really highlight in this, and I'd love for you to go through explain the SCALE framework, so comprehensive, is we don't want you going in, doing something and coming back out. What's the long-term consequence for those patients, and you address it so well in this. And I think for anyone that is thinking about joining one of these programs, just really being able to, because there's so many of them now around the country. And that's one of the questions I had for you. Do you have a handle now on how many different programs there are, David, when you did your research on this? Because it seems like there's some very, very well-developed programs, and there are others that are institution-based, that once a year this group goes to one country to one hospital for a week and then they leave. How did you sort of get a handle on all of this?
Thanks, Pat. Look, I think it was part of such a wonderful subspecialty of people across multidisciplinary, everyone in the team, and really as a craft group of clinicians and who look after cleft lip and palate, you wouldn't find a subspecialty that's more represented in terms of wanting to give back. And that's part of it. I mean, I've done over 40 programs in my career. I've loved them. I've been involved with multiple organizations. And there's no doubt that the intent is well-intentioned. The reason that we go is because we're basically a group of people who've dedicated ourselves to looking and advocating for a group of people who are born either visibly or potentially functionally different in the way they speak. So the intention always is there. But one of the interesting things about life is that a good intention isn't necessarily enough. It's not translated in the way that we would want it to. So the whole idea behind it, as you say, seeing these burgeoning groups that are going across for various reasons, and there's such a heterogeneity from people who literally do pitch the tent through to very well thought out programs. And so this whole idea was this simple appraisal, so that for any person out there who's a nurse or a dentist or a surgeon who wants to go on one of these trips, they can pull out this little paper and look at it and go, well, let's see how the group of people that I'm about to sign up for, how do they fit into, what's the scorecard? It's not saying that you have to fit the scorecard, but it just gives you an idea about what it is, because as short-term volunteers, most of us don't go to these programs with the ability to change how it works. We're slotting into a structure, and that's the responsibility of that structure is on the organization that created that structure. So we're just sort of saying, look, we know this is very difficult, but have you thought about the scale? And it's 5 simple things that relatively helps to put into perspective what we should be thinking about whenever we go to another country to help.
Right. So on that note, let's explain that scale framework to our listeners, because as I said, it is very comprehensive. You guys did an amazing job, really, really thinking of every possible question to ask. So maybe if you could, whoever wants to jump in, Janina or David, or if you want to take turns, whatever.
I think, Janina, why don't you go through it? But maybe I would say that it's comprehensive, but what I like about it is it's also simple. And the word scale kind of just fell. It fell really nicely. It wasn't one of those acronyms which we tried to force our way into. It sort of just fell into it. And so and it's split into 5 broad groups which have specific questions that help you to ask. But really, if you think about each program in terms of these 5 groups, which I'll get Janina to talk about, I think it's a good starting point.
Absolutely. Yeah, no, it's very user friendly. It's one of those things when you create a structure, a document, if it's too complicated, it's just not accessible, so
I think so.
Bravo to you and to everyone. Got to read this when it comes out. Be on the lookout for it. Janina, go ahead.
All right. I'll try to be brief here because we did, as mentioned, try to keep this really simple overall. So the S in scale stands for safety. And the key considerations for that question here are things like, are perioperative outcomes tracked? Does the organization keep track of any type of morbidity, so complications that happen? Do they follow safety protocols? And do the volunteers that work for them stick to their home scope of practice? So the idea being, is this something that you do with your patients back home as well, rather than this being sort of a once a year type of exercise, right? Then the C in scale stands for continuity of care. And I believe Dr. Chong is going to speak a bit more about the importance of this specifically to cleft palate.
Right.
Key considerations here being, are there defined post-op pathways? So who is going to manage complications when they occur? We know they're going to occur. Who's going to take care of these patients? Do local providers have the training? Are they aware of the fact that this type of programs are happening, is there a connection between the providers that did the original work and the local providers? Is that maintained? And again, are those types of morbidities recorded? Then the A in scale stands for accountability. Key considerations here is it clear who is taking responsibility for this program? Are their finances reported? Are they audited or reviewed? So do we know, for example, if you're going to make a financial contribution to a program as well, do we know where that money goes and how it's distributed? Is there a strategy, right? Want to make sure that there's some sense of transparency in what happens in these organizations. The L in scale stands for local workforce integration. This is something that we're both really passionate about. So the fact that even if it is a short-term surgical program, do we recognize some element of local collaboration? Is there an educational element? Is there training? Is there some transfer of responsibility to local providers with time? I think we underappreciate sometimes how much of a luxury specialty or super specialty training is, no matter if you're a nurse, a dentist, a surgeon, an anesthetist. So transferring these skills, I think, is incredibly important, and it's been an underappreciated element in these types of programs. And then the E in scale finally stands for equity. And the questions here focus on patient rights, really. So very basic things. Do we know that informed consents are obtained? Are they obtained in the language that a patient understands? Are the patient's confidentiality and dignity respected? Are photographs not just taken and then shared without their consent? So basically, is there a code of conduct that this organization that organizes this type of mission sticks to? So that, all in all, makes up for scale.
You know, as you were talking, I was thinking about one of the elements, which is the subspecialties. And I think one of the biggest ones, and I know, David, you'll talk about this when you relate it to cleft palate, is the availability of speech language pathology for these kids and for these patients, which, I think for those who don't know, they see the side of the bus, from, Op Smile or Smile Train, it looks like a one and done, cleft lip, close it, yay, we're all done. And as we know, it's so much more than that in most cases. So David, I know one of the things that you wanted to talk about was that there's a very big difference between caring for a child with a cleft lip, especially if it's a unilateral income, it's a cleft lip only. And, that's wonderful if it's a one and done, but in most cases, it's not. So maybe talk a little bit about that concern with these programs, in terms of really looking at cleft palate and caring for those kids comprehensively.
Thanks, Pat. Look, firstly, I just wanted to start off by saying that the big organizations that I've been involved with have done a great job. I think that the intention is always well-intentioned, and there's always an evolution. And that's what I like, that if you can listen, we're not damning anyone here. We're just sort of saying, hey, we're all well-intentioned going out and doing these things. And sometimes we just want to think about what it means, because surgery is not a one-off thing. Once you operate on someone, there is a longitudinal responsibility that we take very seriously from our countries, and we do our best to also maintain that when we go to someone else's country, even when the immediate need is there. It's more than just let's do it. And how are you coping with this longitudinal responsibility? Because in a lot of these places, the system's sick. That's why there's a patient who's 8 years old who needs a cleft lip repair. So if you're just narrowing on that situation, then nothing's going to change for that country in that place. And as you've alluded to, Pat, it's, obviously, yes, a cleft lip is one of the most remarkable operations to see instantaneous change. And the repercussions are, although important, the consequences or complications aren't quite as dramatic as cleft palate. They're really two separate animals, so to speak. And so a cleft lip, yes, it's suitable. And, most plastic surgeons feel like they can do a cleft lip. And even if they're a facelift surgeon or someone who doesn't do that sort of surgery. And we're just sort of saying, hey, you know what? Let's do it the best way that we can. And part of that is listening to the other side and imagining what it's like to be on the other side when all this happens, especially when you're a local healthcare giver and you don't have the time to look after these patients. And suddenly someone comes along, does 50 operations and leaves, and you've got these kids and, lips and palates are like, where do they go? And we all know we don't like looking after someone else's patients at home, let alone when you don't even know what happened in the operation. And especially if there's a consequence that's beyond your scope to look after. And so that's kind of where all this got born out of. And I sort of feel like when I think about it and all the experiences that I've had, that I'm so grateful for these organizations that go in, because there is a very important need out there. But the question is, each country is different. Each situation you go to is different. And to really question your motives about going, are you going there to gain more experience for yourself? Or are you going there because you're trying to fit into a system and make that system better? And that's after, I suppose, all this time that I've committed to doing this sort of work, that it's something that I'd like to sort of spread and also advocate for the local healthcare givers. A lot of them are just heroes. A lot of them have had opportunities to come back to another part of the world and earn a lot more money, but a lot have chosen to stay in their situation, look after these patients. And these are the true heroes. These are the champions that we need to listen to, get behind and support, and help them to progressively, take advantage of our more privileged and certainly more monetized situations, so that when we come into a situation, we're leaving the place longitudinally better. And that's really where this comes from for me.
What I was thinking is that I remember one time I was trying to help refer a patient to see if we could help them find a cleft surgeon that was in their insurance network. And so, I remember that they said, well, we can't come to you because you're not in the network, but this doctor is. And I would call the office. And I remember one time the lovely coordinator in the office saying, well, he's really an aesthetic surgeon, but once a year he goes and does cleft lip surgery to give back, and this is one of the things I'm thinking as I was reading your paper and I was, just having this conversation now, is there is very good intention, but
There is.
It's very
good intention.
And that they feel like, and sometimes it's so funny. I've talked to one surgeon, an aesthetic surgeon. He's like, I sometimes feel guilty. I'm just doing aesthetic surgery. So I go and I give back, and so, that the intention is good, but as you said, Janina, at Palm Springs, you're talking to the people from Mexico who are dealing with, a situation where it sounds like, you get parachuted in, do a surgery and leave, and what's the structure. And I know in Boston this past year, I don't know, David, if either you were at the ACPA meeting, there was a whole pre-conference about all of this. And I don't know, were you there? Were either of you able to be there? Because my question after this was, what's next? They brought up a lot of different issues, and these were even some of the bigger organizations, Smile Train and Global Smile Foundation, and a lot of the bigger ones, is how, because this document, and in your paper, you said it's not an accreditation instrument, nor does it assume that programs lacking formal structures are without value. Rather, it seeks to make explicit the features that determine how care is sustained beyond the operative encounter, like Janina, like what you probably had a lot of conversation with the people from Mexico, and to prompt more informed dialogue between prospective volunteers and program leadership. Dave, I think one of the questions, it's, if there's not regulation on any of this, and you have volunteers going who maybe, are, are doing this work, but sort of leaving behind some of the issues that Janina, that you encountered. How do we move forward with it? How do you improve this? What are you thinking about next steps for you with this work? What's next with this?
I'll just say one thing, and then I'll hand over to Janina. I think that this is an important thing, that cleft palate's one of the most challenging operations to do. It's in a limited mouth. You need suction and lighting. You need a bed that moves. You need an assistant. And those of us who make this our subspecialty realize how difficult an operation it can be. So it's sort of one of those things that sometimes, especially as a subspecialty of plastic surgeons, that we sort of feel that we can operate on all parts of the body. And the other thing that makes it difficult is that because you can't really see what's going on inside a palate, the consequences aren't known for quite a while. I had a very early experience as a young surgeon watching the consequences of that, and someone who was doing pallets very, very quickly, and everybody's saying, this guy's awesome, we need to get him back to do more operations. And then another surgeon who was taking 3 hours, and everyone's going, no one should bring this person back to do surgery, it's terrible. And then I stayed and did the post-op, and every one of the ones that was done by this lady surgeon who had taken 3 hours was picture perfect, and the other one had just holes everywhere and big fistulas, and nobody knew. It was just such an early formative experience for me to go, this is super important for us to understand. And as well-intentioned as we all are, and we can't help but the perspective that we have. So a lot of the organizations for a long time have been more volunteer-centric than what's happening on the ground. And it's not, no one's fault. It's just the perspective that we know. So it's just trying to shift this to sort of go, well, we understand it, but someone's got to say no to the facelift surgeon who doesn't do pallets. And that's the responsibility of the organization. That's one of the factors. We know you're well-intentioned, but we need someone to go over there who knows how to do pallets really well. And you'll find more cleft surgeons will put up their hand when they know the organization is based around this. Going back to the NGOs, that the point that I've worked with all of them, and I love them all. Operation Smile, Smile Train, Mercy Ships, Operation Rainbow, and Global Smile Foundation, and a few. They're just everywhere at the moment. And the interesting thing to me, Pat, and one of the things I said to Janina is, if we could just learn to collaborate, and because there are really, we're putting the poor local surgeon. No one intends for this to happen, but we're forcing them to choose sides, and it's not that intention. That's not what we're trying to do, but that's the byproduct of what happens. And really, they are differing attitudes that bring solutions in different ways. So it's actually quite symbiotic and synergistic. If we work together, we could actually work it, one group going in and teaching, one group going in and funding, one group, helping people to attend conferences. It's all very symbiotic. And so one of the hard things, which is for not just limited to cleft NGOs, but the world, is how do we find a way of coming together to see, if we cooperate, how much more powerful we can be against the common enemy, which is insatiable, which is that children and adults in low middle income countries do not have the healthcare systems to look after them. I mean, that's the big problem. And so that's where scale comes from, in a way of trying to find a commonality, and that there are some places where they have got great local surgeons who do this work, but even they are overwhelmed. So there is a place for programs coming in and some external help, especially in these more remote areas. But how can we use that? How can we listen to the locals so that we're being part of the system rather than just creating more work for them? Janina, I don't know if you want to add anything else to that. And what I really liked about our project is that Janina is super interested in this. I'm sort of on the just past the peak of my involvement. I can feel the downhill slide starting, and Janina is coming up. So I just,
but he'll always be there for. He'll always be there. Yeah, he'll always be there for you.
Exactly.
Well, exactly. But the fact she was passionate about it, and we had struck up this conversation at ACPA in Palm Springs, and I was like, well, this is a great time for you as an up-and-coming person in global health, super interested, and a lot of theoretical knowledge on how things should be done versus my sort of like the experiences that I've gone through, which have been a big part of my career. And how do we write a paper where we can fuse those two perspectives? Janina?
Yeah, I think we're in a beautiful moment, actually, of reckoning and an evolution sort of to a new phase, so to speak. I think there's a lot of conversation clearly happening. ACPA is doing these panels. I think there's been a lot of effort in getting local providers to these conferences to initiate these types of meaningful conversations. So I think we're at a really good starting point to continue on that type of trajectory that's perhaps a bit more reflexive. But overall, I think it's important to consider the fact that obviously we're now in a position where we can do so. So I think there's been a lot of programs in the past with, again, the best of intentions that were structured the way they were because they were responding to real world situations that were very particular. There were constraints there that we could probably not appreciate retroactively. So I think there's just a moment of transition now, and I'm very excited to see what comes. I think, again, we're thinking about co-authoring some work with some of the providers that David's been working with in the field to really start getting them actually out in the academic sphere as well and getting their opinions heard on a more international level and giving them a broader audience, which I think we both hope will really contribute to this evolution as well.
Well, I'm expecting to see this submitted for next year's meeting in Toronto.
All right.
Sure.
Yeah.
No, for sure.
Definitely.
And
David, sorry, go ahead.
So I was just going to say, and that was a relatively purposeful thing on our behalf that we didn't include an LMIC surgeon because we felt like it was an advocacy piece. And also we didn't want this to turn into a political piece.
Right.
This is not about a comment about who's good or who's bad. It's a comment, a paper of all these experiences of well-intentioned, wonderful organizations for which trying to make a difference in the world, and it's like anything that we do. It just is the ground experience of how it can be experienced and an advocacy piece for the people who are being helped. And we didn't want to bring in an LMIC surgeon who might find that difficult at this stage to make this sort of point. So I suppose I'm trying to use my pedestal, for want of a better word, of someone who's done a lot of these and all through my career and not always for the right reasons, and sort of say, okay, I'm not saying I'm a saint. I'm just saying, hey, I've got to this point in my career where I'm just seeing these patterns happening, and what can we do as an organization to give a voice to the people we're trying to help, and how can we think about how we can bring our organizations in, and when we do, create a structure that hopefully follows the scale, or at least contemplates what the scale is, the continuity of care, the safety, the advocacy, the ethics of the patient, and local care involvement. And it's not really that hard when you break it down to those 5 things that you should. And for anyone who's wanting to go on these trips, which I think are a wonderful part of life and helps us all, you realize when you give that there's so much that comes back to you. That's why we all want to volunteer, and that's why cleft lip and palate is so well represented, because of the people that are attracted to do this sort of work. But have a look at these 5 things and maybe ask the organization you're going to work with. Well, you're allowed to ask those questions, and then if you're satisfied, then you put your hand up and say, I'll come with you. I want to support that vision, rather than getting there and then sort of going, oh, geez, I didn't expect this, or, who's going to,
Like informed consent for
Exactly.
surgery. It's informed consent for
informed consent for
participation.
program participation.
There you go.
Yeah, it's
Exactly.
a great way to look at it.
Risk, benefits, and
That's what we should
alternatives.
have called the paper.
No, I think this is, so important. And, and Janina, I mean, just because there are so many of your colleagues who I'm sure are going to be thinking about pursuing, working in these programs as part of, of their of their life. And I think this is, amazing. And so any last takeaways before I reintroduce this paper? Anything you want to jump in with?
No, I'm excited for the next couple of years to see what's come.
And
David?
Pat, I just wanted to thank you for showing interest in our paper. It means a lot to both of us. It's a paper that, I publish a fair bit, but I'm particularly proud of this one. I think I hope that it's read with the right intentions of what we're trying to say. recognizing everybody's desire to give back and well intention to help those that are less privileged in terms of their access to care. And the only thing our paper is saying is, here are some things to think about, for organizations and people who are participating about how we can do things better. And we're all evolving, and we're all, we've all learned, even, as a 50-year-old person. I know I did dumb things when I was in my 20s, probably still doing dumb things now, but you've got to assess it and look at it to be able to evolve and improve. And that's all we're trying to do. So thank you for helping us draw attention to that, because I think the United States and America in particular is a country that gives back a lot to the rest of the world, and ACPA represents that. And so, having a voice in this situation is something that's a great honor, and thank you for helping us draw attention to it.
Absolutely. I just have to run and show you something. Don't go away, everyone. So I just told Janina I was just in Pittsburgh, but my husband brought this book, and he said that has to be our next vacation. There's an area in my apartment where people share books, and he came up with this one, and I thought, whoa, there's a lot to see in Australia.
Well, Pat, I'm just going to put one more plug in here. 2029 Brisbane International Cleft Conference, perfect time.
Yes,
that's right.
And
I'm going to be there. I'm coming. I am coming.
Right.
So let me just reintroduce this paper that is almost about to be published in the Cleft Palate Craniofacial Journal. So look out for it. It's Program Structure and Responsibility in Short-Term Cleft Surgery Programs, the scale, framework, and the authors, and I'm so happy to have both of them here, is Dr. David Chong, who is currently in Thailand, but he is associate professor of surgery, associate in Melbourne, and Janina Kueper, who is a rising PGY5 in surgery in Pittsburgh, where I just was, and so I'm just really happy that to be able to talk to both of you. Thanks for sharing this. Thanks for all of this hard work. I know there's more to come. So thanks so much. Take care, everyone.
Thanks for having us. Bye bye.
Thank you.